Hello everyone. Hi friends. We are back with the last part of the management of AUB. This is the third lecture of this series. In the first lecture I covered the classification of AUB. In the second lecture we were talking about the diagnosis and investigations part, and this is the treatment modality part. As I talked about it, that the treatment could be medical or surgical. Medical means anything which can be oral preparation, injectable preparation, or anything which is kept inside the uterus, any medicine form which is used to control the bleeding, and surgical is definitely a surgical management. Now we also discussed that AUB can be divided into acute and chronic. Acute meant bleeding of such a severity that the patient needed immediate admission and immediate arrest of blood loss, whereas chronic was any bleeding of more than 6 months duration, which is over a long period of time. So acute AUB is mostly an emergency. So what are the goals of management? Number one, rule out pregnancy. Whenever a patient with bleeding comes to you and she is in reproductive years of age, always rule out pregnancy. Pregnancy is not a part of AUB. If she is not pregnant, then first of all assess and then stabilize. First assess the parameters: pulse, blood pressure, how is the patient, is she in shock? Retrieve the patient from the shock, stabilize the hemodynamic parameters, give appropriate management like fluids or whatever needed. And last but not the least, in fact most important, arrest the blood loss there and then. Now how can we arrest the blood loss? Since it is acute AUB, we need immediate response. So conjugated equine estrogen followed by either of these three: oral contraceptive pills, which is estrogen plus progesterone pills, Norethisterone acetate or Norethindrone acetate. This is a highly potent synthetic progesterone, and Medroxyprogesterone acetate is a less potent semi-synthetic progesterone. So first of all, we will give intravenous equine estrogen to stop the bleeding, and then continue with either of the three depending on the condition of the patient, age of the patient, and risk factors. Now conjugated equine estrogen. We give 25 milligram intravenous bolus dose every 4 to 6 hours until the bleeding stops, followed by either COCs or progesterones, as I was talking in the previous slide. Whenever we are dealing with the medical management of AUB, it is always a dictum that give the full dose till the bleeding stops. Whatever method you are using, always give the full dose till the bleeding stops, and then slowly taper down the dose. You cannot withdraw the treatment suddenly because it will cause rebound bleeding. So here in this case, once we are giving intravenous estrogens, we will follow with oral preparations, either E plus P or P, and then taper it slowly. But IV regimen of this estrogen has its own considerations. What are these considerations? That they are not uniformly available, and it is associated with severe nausea. So we have to counsel the patient. Then once it is done, then we'll have to follow it with either COCs or progesterone. Now COC, choice of COC, that which COC should be considered and whether COC should be considered or progesterone should be considered. First of all, look for the risk factors, mainly cardiovascular risk factors and venous thromboembolism risk factors. If the patient is having any of these risk factors, don't go for COCs, because COCs will increase these life-threatening complications. Then opt for progesterones. But if you are opting for oral contraceptive pills, then always choose the one which has at least 30 micrograms of ethinyl estradiol. There are two types of OC pills available in the market, one having 30, another having 20 ethinyl estradiol. Mostly for contraception, low dose estrogen is used because estrogen generally causes nausea. But if you are picking up the pills for AUB management, then pick the one with the higher quantity of estrogen, that is 30 micrograms. And start with a dose of thrice per day till the bleeding stop, as I talked in the earlier slide, and then twice a day for 7 to 10 days, and then once a day for another 7 days. That means 3 times a day till bleeding stops, and then twice a day for further 7 to 10 days, and then only single tablet per day for further 1 week. This shows that we are tapering down the dose and not suddenly withdrawing the hormonal support. Now, if we are going with progesterone, like the patient was having age risk factor or some cardiovascular high risk factor, so we will go for progesterone. And this is the most potent progesterone preparation available in the market. It comes in 5 milligram tablet form. So we start with thrice a day till the bleeding stops, and then go to twice a day for coming 15 to 20 days. Because we want a normal menstrual cycle to repeat again, generally the hormonal management is given for at least 20 to 25 days, and then we stop, and then there is a withdrawal bleed, and then we start again. If we want a low potency progesterone, very low potency progesterone, then we can go with Medroxyprogesterone Acetate, or known as MPA. It comes in 10 milligram tablet form. Start with twice a day until the bleeding stops, and then taper down to once a day for coming 15 to 20 days. So again, 15 to 20 days we continue the medicine in the low dose format. This was all hormonal treatment which we were using to arrest the blood loss. Adjuvant therapy like Tranexamic Acid is also very useful. It is used in initial 5 days to stop the bleeding in a very fast way. Tranexamic Acid is a anti-fibrinolytic agent. We will actually study all the drugs, all mechanism of action in a different, altogether separate lecture, because here we cannot cover each and everything. But Tranexamic Acid is now the drug of choice in cases of antifibrinolytics. It decreases the lysis of blood clots, and because there are more blood clots, so the bleeding stops early. Dose is 1 to 3 gram per day depending on the weight of the patient and requirement of the patient. Then comes surgical treatment. Here we are talking about acute AUB. So acute AUB, in general, acute AUB does not need a surgical treatment. These medical treatments, adjuvant treatment as well as hormonal treatment, are sufficient. But still, if you are failing in medical management, then either you can evacuate or empty the uterus completely with some endometrium, or you can use intrauterine balloon tamponade. What is this? Intrauterine, inside the uterus, balloon, you put a balloon inside the uterus and then inflate it so that there is pressure on the endometrial walls and the bleeding stops. So intrauterine balloon tamponade. Generally we use it for the treatment of postpartum hemorrhage, but yes, their role are said in cases of acute AUB. But having said that, I am still telling that in cases of acute AUB, mostly the medical management is sufficient, and then we can proceed with the final management, and it is hardly needed. Then treating chronic AUB. Now comes chronic AUB, which we understand mostly as AUB. more than 6 months duration. Now we have already diagnosed that the patient is having AUB, and till now we have done the investigations and we know that patient is either having PALM or COEIN problem. So now we will select the most effective therapeutic option and discuss with the patient that what are the pros and what are the cons with them. Now I am going to discuss a whole spectrum of options for you, but we cannot apply each and every option with each and every patient. We will have to talk to the patient what she wants and what is the actual problem. Depending on that, we can manage the patient. So what are the parameters? Once we are talking to the patient, what are the parameters that we will be discussing? Efficacy of the treatment, how much effective the treatment would be, what are her future reproductive plans. For example, there is a patient who is having leiomyoma and she wants to conceive again. So we will go for myomectomy because she wants a uterus inside. But there are patients who are having advanced age, advanced leiomyomas and a complete family, and they don't want any sort of complications in the future. So we go with hysterectomy. And the status of anemia has to be seen and the patient should be managed accordingly. If she is suffering with severe anemia and there are other complications, she may need blood transfusion. If less, then she may need oral iron or intravenous iron depending on the situation. So, efficacy of the treatment, what are her future reproductive plans, and what is the status of anemia, whether she can tolerate the given management right now or she needs some supportive treatment also. Now, as I was talking earlier from the first lecture, you should know whether it is PALM or whether it is COEIN. PALM means polyp, adenomyosis, leiomyoma and malignancy. And COEIN is coagulopathy, ovulatory disorder, endometrial disorders, iatrogenic and not otherwise classified. So those structural lesions, we have already talked about them in detail in each lecture. We have polyp, adenomyosis, leiomyoma, and everything has been talked about in details in my other lectures. So for structural AUB, you have to go for specific management for specific pathology. In this lecture, I will be mainly talking about non-structural causes. So where there is no specific structural cause, we always start with the medical management. Medical management includes non-hormonal as well as hormonal. Now, non-hormonal medications, as I told you, there is a whole spectrum of medications. The basic management always starts with NSAIDs and antifibrinolytics, and then if both of them don't work, then we add hormonal management. Generally, mefenamic acid or naproxen are the drug of choice to be used in AUB. Antifibrinolytics, as I told you, tranexamic acid is now the drug of choice. 1 gram of the tablet twice or thrice. So 1 to 3 grams per day is the dose. Always give the medication in the appropriate dose so that it works. Now, if we want to add hormonal medications to the same, what are the other options that we are having? See, combined hormonal contraception methods are available, estrogen plus progesterone pills. But what we need to know that all of the options that I am going to discuss right now are used cyclically or in continuous manner for at least 3 months. Any hormonal treatment, if you are starting, either you are giving for 20 to 25 days, then allowing a withdrawal bleed and then starting again. You should continue for at least 3 months, only then that is going to be effective. You cannot withdraw before 3 months. Or in some severe cases or some specific medications like Dynogest, you don't allow a withdrawal period and continue it continuously for at least 3 months. So 3 months is a very, very important deadline. Oral contraceptive pills containing at least 30 micrograms of ethinyl estradiol that I have already explained in acute AUB. or we can use a contraceptive patch or a vaginal ring containing estrogen plus progesterone. Normally in oral medications, we don't give plain estrogens for management of AUB because we know that anything which does not have progesterone inside, it will cause unattended and unopposed growth of the endometrium. So whenever you are giving any hormonal preparation for a long time, progesterone has to be there. Now either you can have estrogen or progesterone or only progesterone. So oral progestins, as I talked, Norethisterone, starting with 5 milligram 3 times a day. So 15 milligram per day and then continuing for at least 20 to 25 days. Other one is same MPA as I discussed in my previous slide. And this is a newer progestin which is doing marvels in management of AUB as well as management of endometriosis. 2 milligram per day, and important is continuously. You cannot give a break when you are giving plain Dynogest. So daily for at least 3 to 6 months. These are the oral preparations which are available in the market. Depending on your situations where you practice, the availability and the choice of the patient, we decide any one of them. If patient is not ready to take daily medications, you can go for injectable, that is DMPA, or popularly known as Depo-Provera. Depot preparations of Medroxyprogesterone Acetate. 150 mg injection is available. It is a depot form given deep intramuscular every 3 months. And you can repeat it at every 3 monthly intervals. And most of the cases it causes complete amenorrhea. So it gives a very good result in case of AUB. Then comes intrauterine progesterone. This is something new in the market, but this is very, very highly acceptable and giving very, very good results. LNG-IUS, what is this? This is an intrauterine device fully loaded with levonorgestrel, a type of progesterone. And if it suits, it lasts for 5 years. The most commonly used trade name is Mirena. Then I talked about NSAIDs, I talked about Tranexamic Acid, and then estrogen plus progesterone, only progesterone. And now we are talking about GnRH agonist depot preparations which are available in the market like leuprolide acetate, triptorelin, goserelin. These are injected every month or every 3 months, but they have their own pros and cons that we know very well, and we will be discussing it later in the class of pharmacology of gynecology. Then we have the option of GnRH antagonist also, but in general for prolonged use we don't use both of these things. Earlier GnRH antagonist was only injectable preparation, but now elagolix, relugolix are available in market, which are oral preparations, but now they are under study and companies are claiming it to be very, very effective in cases of endometriosis and fibroid, but we don't know. Then comes selective estrogen receptor modulator or SERMs. Ormeloxifene, Centroman, and at some places it is known as Saheli. So this pill is taken 60 milligram twice a week for initial 12 weeks and then 60 milligram once a week continued for at least a few months. This also causes complete amenorrhea in a long run, and once we withdraw it, we see that whether the problem is still there or we have treated the thing. Then comes selective progesterone receptor modulator or SPRMs, and mainly mifepristone in a low dose, 10 to 50 milligram daily or twice a week. All of these drugs cause amenorrhea. Then comes aromatase inhibitors like letrozole and estrozole. They decrease the estrogen in the environment, so in long run bleeding stops. We'll have to give it continuously for at least 3 months. And other steroid analogs like danazol is available in the market, but nowadays danazol is not used with such a more frequency because it causes high number of adverse drug reactions. So summing up the thing, we start with basics, that is NSAIDs and antifibrinolytic, and add hormonal management. These all other drugs which I have managed, these all are not so much popular, but slowly they are gaining popularity, and we have to see that our patient is a candidate of hormonal medication or non-hormonal medication, or what should we do and how will we proceed. Now what I was talking was that LNG-IUS is relatively new in market, but it has got the maximum result, up to 80% decrease in the blood loss over a long run as compared to COCs, Tranexamic Acid, MPA and placebo. So whatever hormonal preparations are available in market, in long run, if the patient is ready to use LNG-IUS, then you will get the best results in the long run. So after talking so much, this thing, that thing, what do we do? What do we tell to the patient? So LNG-IUS is the best first line management if your patient is actually correct. Your selection of the patient is correct, that the cavity is not distorted, the uterus is more or less normal size, and the patient needs long-term progesterone, then LNG-IUS is the best treatment available nowadays. Then comes antifibrinolytic, that is Tranexamic Acid, which is the second line management, and long cyclical oral progesterones for 3 to 6 months is the last option. So given an option, always give an option of LNG-IUS and then proceed with Tranexamic Acid and then with long cyclical progesterones. Now I'll be talking about little bit about each type in the COEIN. So if you feel, in the last lecture we have seen that in which patients to look for AUBC and how to diagnose. Once you diagnose that yes, your patient is suffering from AUBC, that is coagulopathy, then try the initial basic management first. What was that? NSAIDs, Tranexamic Acid and hormonal management. If you are able to manage with that, fine enough. If not, then manage in collaboration with a hematologist, because as I talked, if the patient was suffering with von Willebrand disease, we need to involve a hematologist also. And then we need to give her some specific interventions such as either steroids or desmopressin, which is DDAVP or 1-D-amino 8-D-arginine. So in the exam, if someone asks you the management of AUBC, first basic management, if not working, involve a hematologist and then go for either steroids or desmopressin. Then comes O. We are going like COEIN. So now O is ovulatory disorders, or earlier it was called as DUB. So since it is DUB, that means there is no structural cause, then always go for any of the hormonal options that I have discussed earlier in that table. But if the patient say that I desire fertility, I am having bleeding problems, but I want to become pregnant, so you cannot give hormonal preparations, because most of the hormonal preparations either work on the endometrium or they suppress the ovulation and the patient cannot become pregnant. So in that case, try Tranexamic Acid plus NSAIDs plus ovulation induction. That solves the problem, because most of the cases of AUB-O are anovulatory patients like PCOS. So if the patient is not ovulating and there is unopposed estrogen in the body because there is no ovulation, so the patient is having heavy bleeding after 2 to 3 months. So what you do, give ovulation induction, ask her to try for a pregnancy. If she becomes pregnant, fine enough, but if not, then also, because you are treating for with ovulation induction, she will be having progesterone in the body. So what you do is just add Tranexamic Acid plus NSAIDs during the periods and keep on giving ovulation induction for 3 to 6 months, and then you will get the results. Now comes E, endometrial causes. So as I told, always start with basic management, that is NSAIDs plus Tranexamic Acid, and a long course of antibiotics should be added for chlamydial infection. Then comes iatrogenic cause, doctor-induced IUB. What is this? Mostly happens during when the patient is taking hormonal preparations for contraception or for some other diseases. So adjustment of the dose should be done. You should take a proper history that what type of formulation she is taking, what is the dose, what time she is taking. Either she is forgetting in between. For example, she is on oral contraceptive pills and she says that sometimes I forget. I take for 2 to 3 days, then I miss for 2 days. So definitely she will get bleeding, spotting time and again. So always take a good history and look for the dose, the formulation, the methodology of taking. Once you settle that, mostly by the 3rd month of usage of that thing, that things will settle down. But if not, you can add some antifibrinolytic like Tranexamic Acid. But if even after adjusting the dose, formulation, routine, Tranexamic Acid, still you are not getting any relief, then you may discontinue the original treatment and let the body heal itself. Now comes AUB-N. What is N? Not otherwise classified. This is something new to our subject and we are still looking for the best treatment for this thing. Number 1 is AV malformation. If you on color Doppler you pick up that this patient is having AV malformation, then the best way of treatment is embolization of the uterine arteries. And nowadays a new thing has come up that there is a caesarean scar on the uterus and it gives way either completely or partially. So what happens with each menstruation, there is filling of some menstrual blood here and this is called as isthmocele, a small collecting pouch at the level of the isthmus or the internal os is called as isthmocele in patients who have undergone 1 or 2 cesarean sections. So nowadays the best treatment for isthmocele is laparoscopic repair of this isthmocele. What I want to say is, like in a sagittal section you see that there is the isthmocele, there is some place here where the blood gets collected. So you laparoscopically repair it again so that there is no potential space where the blood gets collected and which gives rise to post-menstrual bleeding or intermenstrual bleeding. So not otherwise classified is either AV malformation or isthmocele and we will have to tackle them separately. Now comes the surgical management. This was whole about the medical management, that how to proceed with the non-structural causes. Surgical management, how do we decide? Basically on the etiology. If it is the structural thing like palm, treat the specific etiology. Severity of the symptoms, whether it is disturbing the quality of life of the patient and we need to go for a treatment right now or we can wait for the menopause. A response to the medical treatment. We have given all the medical treatment and what was the response? Most important, woman's choice and desire to preserve her uterus. Always give importance to the woman's choice, what she wants. Whether she wants hysterectomy, whether she wants to preserve, she wants to go for some non-radical treatment. Accordingly, we will decide that what do we do. And desire of further childbearing. If she says that I want to become pregnant, then there is no question of removing the uterus. Now, surgical management again, that AUB from structural causes we have to treat the specific pathology, polyp, adenomyosis, leiomyoma, whatever is the pathology, just remove that pathology. But non-structural causes, that is the COEIN, then what can we do? This is the uterus, there is no structural cause and it's bleeding. So either you destroy this endometrium which is causing bleeding, or you remove the complete uterus. You don't have any other option. Now, how to remove the endometrium? If the woman says, I don't want to get the uterus removed, then you will have to remove the endometrium. And important is, as I told in my menstrual cycle lecture, that the endometrium has 2 layers, functional and basal. So in every menses, the functional layer is shed and the basal regrows the functional layer. So whenever you want to do a resection of endometrium, you will have to take out both the layers so that there is no further problem. Earlier, there was only hysteroscopic resection. We used to put a cautery-like loop inside and take out the endometrium from the hysteroscopic method. Now there are newer devices, NREA. This is something very new. Non-resectoscope endometrial ablation devices. You don't have to put inside the hysteroscope. You don't have to put a cautery. 4 options. Either you put intrauterine balloon, the name is ThermaChoice. Either you do a cryotherapy on the endometrium and just destroy the endometrium, the name is her option. Free fluid, the name is hydrothermablator. Or radiofrequency destruction, the name is NovaSure. ThermaChoice, her option, hydrothermablator, NovaSure. Very new modalities. But how do we decide that yes, we are going to do the ablation procedure? So these are the prerequisite. That patient has a complete family. She cannot become a mother again because we are destroying the endometrium. Pathologies like hyperplasia and malignancies are ruled out. Always do a biopsy first. We are not dealing with a carcinoma. And patient note that there is a possibility of failure in this procedure also. We are trying to destroy both functional and basal layer, but if they don't get destroyed, then we will have to proceed with a hysterectomy. And patient should be ready to use contraception because we have to avoid pregnancy. So what are the prerequisites? Family complete. Patient will not become pregnant again. There is no malignancy. We have ruled out the malignancy and we have told the patient that we are trying to ablate the endometrium, but in some cases we need to proceed with the hysterectomy. These procedures have a very good patient satisfaction results with fewer complication and anesthesia requirement. So definitely before hysterectomy, in cases where we know that they are a good candidates for ablation, always try ablative procedures. But finally, if nothing is working, then hysterectomy is the answer. Just remove the uterus and get rid of the bleeding. And how many types of hysterectomy, how to do, when not to do, I have totally described in very detail in each type of hysterectomy lectures. Now this is the last slide where I just want to give you an overview of how to manage a patient and when the walk-in patient is coming 1, 2, 3, 4, what to do. Patient comes, a good history and physical examination, very, very important. A good history and physical examination will solve half of your problems. And then number 1, always pregnancy test. If it is positive, the whole story is different. Go towards abortion, ectopic, whatever it is. And if it is negative, then complete blood count, hemoglobin, platelet count, thyroid, coagulation studies, prolactin, look for any infections and pap smear. If anything comes out to be abnormal in this, then go for specific management. If they all turn out to be normal, then if she is having acute AUB, she is bleeding severely, then what do? We go with a transvaginal sonography or endometrial biopsy. If the patient is having a hemoglobin less than 7 or she is having orthostatic hypotension, that means she needs emergency management. Consider blood transfusion and immediately hospitalize the patient. If the hemoglobin is up and the patient is not having any hypotension, then we can give outpatient management in the form of basics. NSAIDs, Tranexamic Acid, IV, estrogen, oral estrogen plus progesterone or progesterone, whatever it is. So you, according to the condition of the patient, if she needs hospitalization, hospitalize and manage. If not, you can go with oral medications. Then comes chronic abnormal bleeding. First decide whether the patient is having high risk for malignancy or low risk. If the patient is low risk, then start the medical management immediately and then go for observation or continue medical management. But if she is high risk and she is not responding to medical management in cases of low risk, see, either she was high risk or low risk. If she was high risk, then straight away we go for investigations including transvaginal sonography and endometrial biopsy, because she was a high risk for neoplasia. But if she was a low risk for neoplasia, we always try a medical management first. If the medical management is not working, we go for transvaginal sonography or endometrial biopsy. In transvaginal sonography, there was a normal cavity and nothing to be said. Then you continue the medical management and try to manage the patient on the medical management. But if there is abnormal cavity, then go for saline infusion sonography or hysteroscopy guided biopsy. Depending on the result, proceed with surgical management or medical management. But here, if she was a low risk and she was responding to the medical management, we can go with the same medical management. And once she starts not responding to that medical management, or during the endometrial biopsy or something we find some abnormal findings, then go for a disease specific management. Take home messages: always take a good history, physical examination, rule out pregnancy, basic test, and then proceed with the management. This is how we conclude the management of AUB, and hopefully now we are able to write our short notes as well as answer the Viva questions. Thank you so much.